all that much about the left gastric. So, but ultimately what we want to be able to do is to see the relationship of the pancreas, the body, not so much the head yet, but the body and the tail of the pancreas as they come across the aorta. And remember that this is, even though we've kind of torn away this is all retroperitoneal. Okay, so it's lying behind that peritoneum. And then its relationship is the tail at this point is just pushing into the hilum, or this inside concave surface of the spleen. And here you can see the splenic artery kind of going over along the superior border, and we have kind of a bend in it that we've already started to identify in the cadaver. And then as it bends behind there and then enters into the spleen. When we look at it from the venous side, here's the splenic vein, and it's running right down through the middle of the pancreas. Okay, understand that even though this is translucent, it makes you want to think it lies behind the pancreas. It's actually lying in the pancreas itself. And as it's running through here, think about it from the point of view of especially the tail part of the pancreas. The tail part of the pancreas is where the endocrine function is located. Okay, so that's the glucagon, that's the insulin, that's the islets, the islet cells. So that's where we're generating that hormonal response to the control of circulating blood sugar, whether we're releasing blood, where we want to release sugar for energy, or we want to store it. But the tail part of it then becomes the endocrine function of it. And then as we go to the body and on towards the head of the pancreas, as it's nestled into kind of the retroperitoneal part of the duodenum, is really the exocrine part, which is all of the digestive hormones. Okay? So those two pieces are kind of what we want to do. Along this inferior border of the pancreas is where we're going to see the branches, or at least try to identify the superior mesenteric artery. And again, we're not going to get involved in trying to identify all the different branches of these. I just want to be able to let you see the trunk of this, and with a little bit of luck, some of the kind of the cascade of vessels going out towards the intestines. We're not going to name them or anything like that, but ultimately be able to see that superior mesenteric artery. Same thing goes up here with respect to the celiac trunk. We want to be able to get you at least to see the two primary branches, hepatic and splenic, and then we will look at the hepatic a little bit more as it goes towards the liver, but then not worrying about branches that are forming the vasculature around the greater and lesser curvatures of the stomach. Okay? Now, I'm not going to worry about innervation of that because I don't want to have to dissect. It's all about me. Okay, so now we have the pancreas. Vessels are kind of stripped out of there so that there's not a great sense of that vasculature. But now you can see this pancreatic duct system that's coming all the way through from the tail of the pancreas all the way through, and ultimately ends up and splits into an accessory pancreatic duct and into the primary or main pancreatic duct. And then the thing that you see here kind of here to here is the bile duct as it comes in at the same place. And then there's this duodenal papilla right here, which is really just an opening or a sphincter by which both bile produced by the liver, stored by the gallbladder, as well as the pancreatic enzymes, those digestive enzymes, the exocrine part of that, are dumped into the duodenum. Okay? Now, if you look at kind of this image right here, this is kind of a blow up right here of this area right in here. In other words, we have the main bile duct coming through. So here's our bile duct. The red lines are just to imply that there's smooth muscle in there, which forms a sphincter. In other words, under autonomic control, the smooth muscles in these sphincters are generating responses that say, let this digestive juice go into there or not. So we want to release bile, we don't want to release bile. We want to release, and again, so two separate sphincters specific to the bile duct in the main pancreatic duct, but then once they get to this component right here where they've fused together, again, there's another sphincter there that as the two mixed is then releasing it into the duodenum. Now, if you think about what these are doing, so we have bile, this bile is designed to dissolve cholesterol and things like that, as well as we have the digestive enzymes of the pancreas. So the common ones, lipase, amylase, protease, all of those things as they're dumped in there, depending upon what the signals are, what the chemical signals are in the duodenum, tells us whether we're going to release more bile, less bile. More pancreatic enzymes, less pancreatic enzymes. What kind of pancreatic enzymes are we biasing towards? So in other words, if we have kind of a large carbohydrate meal, we're having bagels. So that the idea is that once that digestive product, the chyme from the stomach, gets into the duodenum, then the chemical signals that are in there says there's a lot of carbohydrates there. Then what it's going to do is it may not, unless you put a whole lot of cream cheese on it, it's not going to release a lot of lipase, but it is going to release a lot of amylase as part of that breakdown of that carbohydrate diet. So the signals, the hormonal signals, the chemical signals that say what is the, so just so you guys know, there was a ladder on the other modular, and so I'm not sure what they're doing up there. Hopefully we don't lose electricity. It doesn't go without kind of a word of caution. So, but anyway, so when we look at the pancreatic function and in terms of the enzymes, it really is under the control of what the stomach is seeing in terms of what that digestive meal looks like, in terms of how much carbohydrate, how much fat, how much protein, and then ultimately when it gets into the duodenum, same thing. Those chemical signals are telling the pancreas how to kind of tailor what that ultimate quantity and ratio of different enzymes are that are dumped into that pancreatic duct system. And again, how much of that has to be emulsified with respect to the bile? How do we need that? And then ultimately, those two sphincters are controlled by that. And then finally, this last sphincter controlled as it dumps this into the duodenum. And this is just an image of radiopaque dye into the cystic system. Okay? Now, if we look at it from the point of view of the liver, so the other day when we did the liver, here's that falciform ligament. So that's that kind of between the two major lobes, the left and the right lobe, there's this large falciform ligament that's anchoring the liver to the anterior abdominal wall. It also fans out as these coronary and triangular ligaments on the top of the liver that anchor it to the diaphragm. So it's not like the liver can just flop around in there. And then here's this round ligament of the liver again, also could be called ligamentum teres, but it's just a remnant of the umbilical vein, of that placental oxygenated blood coming into the fetus, okay? And then if we look on the posterior side, there are two smaller lobes that are listed in here that really not all that critical. They don't have anything. There's no different function to them than there are to the left and right lobes. So the quadrate and the caudate lobe, there's no different function. They have the same histology. They have the same kind of hepatocyte arrangement. But they're related to kind of this midline piece. And so right here, if you followed this through, so here's the falciform ligament. If we could follow it through, and it really doesn't follow through, but still that division between the left and the right lobes as we come into this inside is where that attachment of the lesser omentum is located. So remember when we talked about mesentery last week, we said, okay, if we, and I drew on the board kind of how we had something, an organ system that was interperitoneal, and that really the whole system was developed that way, but that the retroperitoneal part of the gastrointestinal system, not the kidneys, but of the gastrointestinal system, as that kind of that supercoiling took place, some of those organs flipped to the back, to the side, and then were anchored on the side as retroperitoneal. In other words, there was a reconfiguration of that mesenteric lining that then anchored certain structures to the back wall. Ascending, descending colon, the duodenum, the pancreas. All of those pieces ultimately were developed intraperitoneally, but then became retroperitoneally during that development. So, and part of that was the formation of the two omental linings. One, the greater omentum, hanging off of the transverse colon, curling back to the greater curvature of the stomach. And then the lesser omentum that's, again, coming off of kind of the difference between the left and right lobes and going to the lesser curvature of the stomach, okay? Now, when we look at this on this inferior or posterior side, so here we're kind of looking at it posteriorly and looking up, here kind of outside of everything. But here the gallbladder is located. And then there's this duct system. Here is this portal triad. Okay, it's an area that lies relatively isolated outside of that mesentery. So here we have the bile duct or the cystic duct. We have the portal vein that's carrying that portal blood supply. It's already a venous blood supply, but it's the blood supply that was specific to the colon and to the small intestines. And then there's the hepatic artery. So that's that portal triad right there. Huh? When we get up here to the superior part, again, now we're up at the diaphragmatic level. Here are the hepatic veins as they're opening into the inferior vena cava before it pushes through that diaphragm, that hiatus in the diaphragm. So remember, there was a vena cava or a caval hiatus. That was that inferior vena cava pushing through from the abdominal to the thoracic side. And at that point, as it goes through there, has already contained, or it's already had converging on it, that hepatic vein system. And again, the hepatic vein system is this portal venous blood, the arterial blood, as it's being circulated within the sinusoids of the liver, to then add to how we do whatever the liver does, whether it's detoxification of alcohol, whether it's sequestering of glycogen or release of glycogen as glucose. All of the pieces that are doing that are a function of the blood supply entering the liver at this point, and then the end product of that is how is that processed and then going through the hepatic vein into that vena cava, okay? So it's not like it's going back to the gut. The only thing going back to the gut is how that system works on the inside to then produce bile salts, or bile that are then sequestered back into the gallbladder, okay? And this is kind of that. So here's our greater curvature of the stomach. Here's that esophageal hiatus. So this is the cardiac end of the stomach, coming down and ultimately to the pyloric region, pyloric valve going into the duodenum. And here's the lesser omentum. Here's that connective tissue band, that mesenteric band from the lesser curvature over to the back side of the liver. And here's that portal triad right here. So we have the blue that's kind of situated behind there is the portal vein. We have the hepatic artery coming in, branching to the different lobes. And then we have this series of ducts that are coming out of the liver. So these hepatic ducts are carrying bile out into this bile duct, into these cystic ducts, and some of it backflows into the gallbladder as a means of storage. So we don't need that constant supply of bile being pushed out into the duodenum, but it doesn't matter if it is. Think about somebody who's had their gallbladder removed. They might have to modify their diet a little bit, but the ultimate end of that is if we take the gallbladder out for whatever reason, then we just have kind of this constant flow of bile through the bile, ultimately into the bile duct, into the pancreas, or through the pancreas, into the duodenum. And this is only serving as storage. Now, why does it do that, and how does it get rid of that? Again, it's all under hormonal control and under exocrine enzyme control, depending upon what the need is for use of bile in the duodenum. Stimulation, smooth muscle contraction, push a little bit of extra bile through that bile duct to get into the duodenum for fat emulsification. Okay? But it's all related to kind of this region right here. It's a little misleading the way it makes it look like it's kind of dumping into almost to the pylorus. But that whole portal triad lies behind the stomach, or the pyloric region of the stomach, to get to the head of the pancreas. Okay? Okay, so these two pictures are only in here not from the point of view of we're not going to worry about the names of sympathetic ganglia or any of that kind of stuff. I just wanted you to be able to see kind of, so here we're looking at, here's our celiac trunk, here's our hepatic artery going in, here's our gallbladder, our cystic duct coming down to common bile duct, which would eventually get to the level of the pancreas. So the relationship of that, so this is just a cut surface, the similar picture as before. Here's the cut cardiac end of the stomach or the esophagus coming through that hiatus, okay? Okay, so here's more, so this is a transverse section. So here are the ribs. Here's the liver sticking up under here, diaphragm coming up. We come all the way over behind here. So here are the right and left hepatic ducts. So that's the end product of the arterial supply in the portal vein going into the liver for taking care of whatever it's carrying that needs to detoxify. But ultimately then the end result is the production of bile that then comes out of these two ducts and comes towards, so the common hepatic duct, and comes towards the bile duct. Now if this is blocked right here, smooth muscle, again, so down, if we go all the way down to the bottom of it, there was a sphincter all the way down there. If that's blocked down there, but again up here, it's still smooth muscle activated. So if this is constricted up here, not from the point of view of it being a specific sphincter, is that bile, as it's constantly being produced, ultimately gets pushed back in to the gallbladder by way of by way of this cystic duct. So now it's stored. So one of the primary enzymes, you don't need, this is not in the test, but one of the primary enzymes which causes a release of or a contraction of smooth muscle of the gallbladder is cholecystokinin, which is released by cells within the stomach lining. Okay, and that gastric cholecystokinin says this is what's coming down, what will eventually get into the duodenum, and that gastric cholecystokinin ultimately influences smooth muscle activity in the gallbladder. Cholecystokinin causes that smooth muscle to contract. Smooth muscle contraction pushes bile back out, now into the common bile duct, on into, as it joins the pancreatic duct, to dump into the duodenum. Now there's a reason for it to be there. Stomach said there was, okay? So here's that kind of the simple histology of that. So here is our portal triad over here. Here's our portal vein, our hepatic artery, and then here's our bile duct. Okay? Now, as that blood flow comes in, so here's our portal venous blood coming into here, and then here are our hepatocytes, and specific to the hepatocytes are the formation of bile going the opposite direction out to those bile ducts. And then here's our arterial supply to there. When we look at it specific, remember we had a portal triad out at the root of the liver, which was the hepatic artery, the portal vein, and the bile duct. Well, we have that same triad at the kind of this juncture point of all of these hepatocytes, okay? The end product of all of that filtration and production is to put a venous blood at this point into these central veins, which then all collect to become the hepatic veins, which dump into the vena cava. Okay? So here's a little more detail of that lymphatic or cystic and pancreatic relationship. So body, neck, here's our cystic duct, common hepatic duct, our hepatic duct's coming from the liver, fusing right here, and then then as we continue down, this common bile duct coming all the way down joins with the main splenic duct, okay, or pancreatic duct. So the way they have this designed, it looks like, so main's going this way. There's this accessory duct here that is functional and really does allow for a certain amount of pancreatic enzymes to be leaked into the duodenum without having to have it be controlled specific to the relationship of the main pancreatic duct and the bile duct to go into the duodenum together. Okay, so this is kind of a constant supply. This is more of a metered supply. Okay? Any luck at all, I'll get that dissected out, at least to the main. Accessory is usually pretty hard to find. Okay, same thing. Okay, so here's, when we look at this, what we're looking at is kind of this venous return. Okay, so all of this portal piece, so you see kind of this, the darker purple or blue, all of this is the portal piece that ultimately goes through the liver. But the lighter blue part of this is all the musculoskeletal venous return. So here we have, so epigastric veins. These are coming from the anterior abdominal wall. We have iliac veins, external and internal. These are coming from pelvic and abdominal musculature, okay? So what they're showing down here is really its relationship to the rectum, not so much of why is it there, but because it's part of that musculoskeletal piece, which we ultimately will either talk about towards the end of the day or on Thursday, okay? But ultimately, through this iliac system, we then form the vena cava. The vena cava goes up, goes behind the liver, and at this point, as it's going through the diaphragm, we ultimately have it being joined by the hepatic veins from the back side of the liver before it's going through there, okay? Now, if we looked at this specific to, for our purposes, think about what we saw on Thursday. So we're really kind of looking at this side, okay? We pushed the guts to the other side to the point where we could see, while the spleen isn't in here, or the pancreas isn't in here, here you see the spleen, this concavity or the hilus with the vessels going in and out of there. Here's the celiac trunk, superior mesenteric artery, and then here's the renal vein coming from the hilus of this left kidney, crossing over or crossing underneath the superior mesenteric artery to get into the vena cava. And what it's doing, it's lying superficial to really deep, depending on where we go. So if we're talking the posterior abdominal wall, superficial to the structures. So underneath it is that hepatic artery. Okay? This relationship that you see here of the abdominal aorta and the vena cava is relatively consistent. In other words, this aorta is going to be shifted a little bit to the left, with the vena cava shifted a little bit to the right. Now, specific to that going down, we kind of got to a point with shoving everything to the side that we could see kind of that bifurcation of the abdominal aorta into the common iliac arteries, and then on down we could kind of see at some point the bifurcation into internal and external iliac arteries. Okay? Now, the other thing that we were able to show, now what we did to get to that point, though, is we took this component right here, which is the descending colon, and we pushed the descending colon to the other side with the abdomen, which then broke this retroperitoneal lining. Okay, so that's critical. At this point in the living human, this is all retroperitoneal, and so that peritoneal lining would be covering all of this. Okay? But to get to the kidney and to get to the underlying muscles of the posterior abdominal wall, psoas major, what we did was we broke that retroperitoneal attachment and pushed it all to the other side with the small intestine. And in doing that, what we left was we left the ureter, at least for now. I'm pretty good at tearing it, so, but at least for now, the ureter was left intact, and we kind of left it right about here without doing much in terms of dissection more inferior into the pelvis. Okay, so that's kind of that perspective that we have right now on the one down. Now again, if we want to look at it specific to the peritoneal foldings,
here we have that, here's our portal triad right here. Hepatic vein, hepatic artery, or portal vein, hepatic artery, and cystic or hepatic ducts, okay? Here's the duodenum sweeping around. So this, kind of the filmy imaging right here is all the way of indicating that these pieces are all retroperitoneal, okay? So kidneys retroperitoneal, duodenum is retroperitoneal, although there's a folding of it at this point. Pancreas is retroperitoneal. Go to the other side. Kidneys still retroperitoneal. Okay. Now, when we look at the kidney, so we talked a little bit about terminology with the lung, okay? The terminology of any one of these organ systems where there is an opening by which veins travel in and out and other things travel in and out. In the case of the lungs, that was the trachea. In case of the kidneys, that's going to be the ureter. In case of the liver, that was the cystic duct. When we talk about that, the area that lets all of those things come in and out of is called the hilum, or the hilus. The structures themselves that are entering and exiting are called the root. So when we looked at the lungs, the hilum of the lungs was that area in terms of that folding of the parietal pleura to the visceral pleura that allowed for the bronchial vessels, which we didn't really talk about, the pulmonary vessels, both pulmonary artery and veins, as well as the primary bronchus, to go through that connective tissue opening. That's the hilum, or the hilus. The root is the combination of the structures, pulmonary vessels and the trachea. When we look at the kidney, the hilum is just this kind of this depression on that medial side of the kidney, and the root are the structures, the renal artery, renal vein, and the ureter, the things that are going in and out of it. Okay? Now, we will cut one of the kidneys kind of in this coronal view so that we can go in and look at the inside of a kidney. So when you look at the inside of a kidney, what you see is you kind of get this sense of it's really kind of just different colors. And this outer kind of paler area that actually goes in, is all the renal cortex. And kind of this reddened area in the middle of that is the renal pyramids. And the renal pyramids are the location of the exchange, really the best way to say it is the exchange part of the nephron, or that histological component of the kidney. In other words, this is where filtration takes place. This is where the release or the resequestering of water takes place. The exchange of ions takes place. So those loops of Henle, if that's a terminology that you're comfortable with, is where all of that's taking place. The other part of this, out in the cortex, as well as to some extent in the pyramids, is where really the Bowman's capsules, or that top end or the front end of that nephron is located. Okay? But ultimately, where those particular pieces are located in the pyramids, there are pieces of them that all sort of come together in terms of the collecting ducts to then merge together into these larger kind of rivers, if you want to think about it. And these rivers, or where all the collecting ducts are located or coming together, are separated into minor calyces, which are really at the apex or the point of each one of the papilla. And as you have more than one minor calyx come together, then they form this major calyx. And this major calyx then is really just kind of, the river gets bigger and bigger. Here you can see a minor calyx coming into this major calyx. Again, that's what these openings are to imply. And then this major, as these major calyces come together and fuse, they form this kind of this large pocket or sac, the renal pelvis, and then that then continues on into the ureter. Okay? When we get out into that calyx piece, there is really no filtration left going on. It's all a function of collection of the urine at that point. Okay? Oh, I wanted to say something about this. So they show the adrenal gland or the suprarenal gland kind of displaced above the kidney, the superior pole of the kidney. It has really, in terms of its relationship to the kidney, is more of a positional relationship, although there's some hormonal links between kidney function and adrenal function. But for the most part, there really is, they are two separate organs with two separate functions. I have that one adrenal gland out specific to the left side of the one cadaver, and we won't cut it open just to be able to see the difference between the cortex and the medulla. Okay? We'll just know that it's there. All right? Although it does get a blood supply that's common, that are branches off of the renal artery. Okay? So now if we look at the kidney specific to its relationship to that, mostly to what I want you to think about is that posterior abdominal wall, because I've kind of messed that up. So kidneys up here, here's the renal pelvis, the ureter coming down, and you kind of get a sense back here, although not too well, is that this whole thing, kind of these strips right here, are really the fibers of psoas major, okay, that posterior abdominal wall. Out here are just the kind of the curls of the small intestines. But the ureter then crosses, so here's L5, here's the promontory of the sacrum. So going forward, we can kind of, if we draw kind of this imaginary line like this, and going specifically to kind of this bump in the pelvis, right here is the arcuate line. So kind of, if you think three-dimensionally out into us, kind of from the promontory out, this is called the arcuate line, and this is where the kidney or the ureter is dropping into the false pelvis and then eventually crossing this arcuate line and dropping into, and now you can see the bladder. So you can see kind of the opaqueness of the dye system in there, and then filling of the bladder right there. So the ureters are coming into the posterior part of the bladder. I don't know why I put that there. Oh, I know why I did. Not because of this. This is kind of what it, so remember when we talked about, we go backwards to the heart. We remember that we were looking at kind of these intercostal spaces right here. Here's C5 intercostal space. Here's C4 intercostal space. Remember, we were taking, and these were areas right in here where we were able to listen, or we were using the fact that there was no bony overlayment, that there was a piece there that we were just going through intercostal muscle to then be able to understand and to hear the valve sounds, okay? So when you think about that, you're kind of right in here. Imagine here's our diaphragm kind of capping our liver. So our heart, so here's our sternum, our heart is kind of lying tilted like this, and that right side of the heart is laying right down on the diaphragm as it sits right on top of the liver, okay? And then the esophagus coming behind that, remember it's behind the heart, behind the pericardial sac, and that posterior part of the inferior mediastinum, that as it comes in there, now it's coming through that hiatus and then filling this cardiac end of the stomach into the fundus and finally down into the pyloric region, okay? So this is just, again, sort of the surface anatomy piece of trying to understand that relationship, okay? So again, notice in terms of our diaphragm that on this right side, that the doming of the diaphragm comes up higher than it does on the left side because we have the liver kind of pushed up in that direction, where on the right side, the spleen is positioned down about 1 inch to 2 inches. And it's actually kind of lies posterior as well. But then to see its relationship to the stomach coming through like this. So in this image, the liver is all the way out to here with the left lobe. Here's the lesser curvature of the stomach. Here's the esophagus coming in. And then the spleen is kind of positioned behind the fundus of the stomach, okay? And then that way, on that one, you can see how far posteriorly it's positioned, okay? This is just to give an idea of breathing. So if you had a patient that said, you know, I have this pain in the right side of my chest, and as they breathe, the chances that that pain migrates up and down, specific to inspiration, expiration. Remember that what's happening is we're changing the position of that diaphragm. Contraction of that diaphragm that's coming from here and domes up like this and comes all the way back. In inspiration, it flattens out, and that during inspiration, it necessarily forces the liver down. And as we expire, not die, expire, but breathe out, then that muscle relaxes, that diaphragm muscle relaxes and domes back up, and just this abdominal pressure at this point pushes the liver back up. Now remember, that liver has that ligamentous attachment to the underside of the diaphragm. It's got that falciform ligament that is running through, pretty much through between the left and right lobes. It's anchored to the anterior abdominal wall. It's got the coronary ligament at the top that's attached to the diaphragm. So regardless, depending upon what that diaphragm's doing, it's pulling or pushing that liver up and down. So that if you have a patient that has pain specific to problems with the liver or the gallbladder, that pain, they may say that pain kind of travels up and down, maybe 1 or 2 inches. And then you ask them the question, does it happen specific to when you breathe? And they answer yes. Understand that because of the liver and its movement, because of the diaphragm, not because the liver just wants to move, but because the diaphragm needs to move, that it can cause that pain to migrate or to change its position relative to breathing. Okay? Now, so this is for this purpose, all I put this in here wasn't to show kind of the relationship of the levels of the kidney and the spleen specific to the back side, and to say, okay, we're at T12 and we're at T11. Just kind of that idea of the liver's there. But what I wanted you to do, think about specific to kind of this posterior lateral wall of the abdomen, okay? So here's our external oblique muscles, okay? And then we cut them away. Here's our iliac crest down here. We talked about the idea
of the epimysial layers of those abdominal muscles and how they form the thoracolumbar fascia. And when we go up to here, so here are our ribs, right here. Remember that our external intercostals are coming off of those ribs, kind of interdigitated, specific to these erector spinae muscles going up. Well, if we get to that level, here's our rib, we separate those and we can go through those abdominal muscles, and now wedged behind there is the kidney. So we've gone in from the posterior side, not through the abdominal side like we did to expose it in the lab, but now we can go through it from the back side, specific to the ribs, to get to those kidneys. If we do it on the right side, it's pushed quite a ways down because the liver's there. On the left side, it's a bit higher. I'm going backwards, left side or right side, left side, sorry. So right side's lower, pushed down because of the liver. Left side, it's up a little bit higher and more obscured by those ribs. Okay? Still, you can get to it from the back side underneath the rib cage. Okay? Now, I'm going to do something. Can't see. I'm going to skip through a bunch of stuff here because I wanted. I can't. Okay, so what I want to do, and this kind of may be a little bit out of context, but what I want you guys to think about as we go forward is this is an image, again, through a horizontal picture. So here's our sacrum, then we're going around to the pelvis, so here's our arcuate line. So now we're at that limit between where we are looking at the abdomen to the pelvis. And the thing that I want you to think about and to put into play here are a couple pieces that we've talked about but never really seen yet. Okay? So what I want you to look at, two things. Is one is this image, but I want you to be able to kind of transfer this image to this image. And we're not worried about the holds. I'm not worried about the holds yet. Okay, or the rectum at this point. What I want you to think about is what we've talked about in terms of the gluteal muscles and the gluteal region and the muscles specific to the gluteal region that are all really lying within the pelvis. Okay? So what I want you to think about first is this image. Okay? So here are the wings of our pelvis. This is actually the ilium. Here's the acetabulum. And as we go more inferior, depending on where we are in that formation, it could be the pubic bone, the inferior ramus of the pubic bone, or it could be the ramus of the ischium. But basically, we're looking at that bottom part of that bone as it's related to this muscle right here. Okay, this is obturator internus. Up here is the iliacus. Okay, so think about that specific to what we've. You kind of go backwards and imagine what we thought about in terms of gluteal muscles, looking at them from the posterior side. We reflected gluteus maximus, we saw piriformis, we saw the end product of the gemelli, obturator internus, quadratus femoris. Okay? Now, so
just as a starting point, what I want you to think about, not so much iliacus right now, but obturator internus and its relationship to this group of muscles right here. And this group of muscles right here, we're just giving it a common name called levator ana. Okay? Now, let's go back up to, whoops. Okay? So everything that we've talked about in terms of the abdomen is really our structures that are lying above the iliac crest, for the most part, but also lie down in between the iliac fossa. So in the green area, the lighter green area up above, that all of this area, which now has specific to muscular covering, is iliacus muscle. That's all false pelvis, and that has abdominal organs in it. Okay? Or it's called the greater pelvis. Then if we follow at the red line up above, as that red dashed line goes over the kind of the anterior part of the sacrum, which would be S1, it's called the promontory, and continues around, then there's this ridge that runs on the inside, which is called the arcuate line, and that's the red line coming around, which ultimately ends out at the pubic bone or at the pubic crest. That red line divides kind of this area above and this area below into the greater pelvis, which is really abdomen, to the true pelvis below that, which is where the pelvic visceral organs lie. And those are the bladder, reproductive organs, as well as the continuity of the sigmoid colon to the rectum. What else did I miss? That's pretty much it. I said reproductive organs, right? Okay. So the whole idea of this discussion is we've talked about stuff up here. Iliacus as part of iliopsoas, which gives us hip flexion. We've talked about muscles in this region that are forming kind of those lateral walls. Here's our obturator foramen, ischial spine, greater sciatic notch, lesser sciatic notch. So we've talked about the relationship of iliacus going out to the femur. We've talked about obturator internus muscle, so it's coming from here and then sweeping around and going out to the gluteal region through this lesser sciatic notch between the ischial spine and the ischial tuberosity. Superior gemellus is coming from here. Inferior gemellus is here. If we look at it laterally, now we're out here, so here's our ischial spine. Superior gemellus is from here. Inferior gemellus is from here, and this notch is where the tendon of obturator internus is coming from the inside or the back side of the screen off this obturator foramen and coming around. We have coming out of this greater sciatic notch, we have the piriformis muscle. So when we look at that image, when we look at this image, now we're looking in this horizontal section cut through here. Okay, so sacrum, here's our arcuate line coming around. So kind of right at that transition from the false pelvis to the true pelvis. And we look out to the side, well, what do we see in terms of muscles that are here that we've already talked about? Here's piriformis coming off of the sacrum on the inside of the pelvis, and then going through that greater sciatic notch to go to the femur. Here's obturator internus coming from inside of the pelvis, coming to the outside through that lesser sciatic notch to attach to the femur.
So these lateral most parts of this are all formed by muscles that actually are components of gluteal muscles, that kind of the relationship of how we looked at movement of the femur specific to the pelvis. Okay? The piece beyond that, though, is that now you see this connective tissue band right here. That connective tissue band, in part, helps to form the attachment of muscles of the pelvic floor that ultimately do a whole bunch of things. They're responsible for kind of our voluntary control of urination. They're responsible for our voluntary control of defecation. They're responsible in part for strengthening of that pelvic floor to maintain those, but also to facilitate in normal sexual response. So this whole pelvic floor, not only is it related to muscles that we've already talked about that have kind of this musculoskeletal action specific to the lower extremity, but also to the pelvic floor. Okay? Yes?
The connective tissue is the levator ani?
Now, this connective tissue is just called the tendinous arch. Levator ani is actually, and we'll talk about that, levator ani is this combination of sort of these slings of muscles. Okay? And we'll talk about why we call it that. But basically, it's a series of muscles that kind of attach anteriorly and sweep around sort of the visceral openings of the pelvis, whether it's the rectum, whether it's the vagina in women, or whether it's the urethra in both of us. Okay? But ultimately, this pelvic sling, combination of puborectalis, ischio-coccygeus, so coccyx bone is right here. So get my bearings here. So pubococcygeus, puborectalis, which is this sling of muscles, fibers that come directly off the inside of the pubic bone and just skirt right around the posterior part of the rectum. Pubococcygeus, and then iliococcygeus. I think I did that wrong over there. But coming off the ilium. And then there's another separate muscle called coccygeus that just comes from the ligament into the coccyx bone. Okay? So levator ani is a group of muscles. And before we get to it, because I'm going to quit right here, basically what it does is it forms a sling. And our external sphincter is really not so much, although there is a sphincter there, it's really aided by contraction of these muscles and from the anterior point that basically pull all this viscera forward. And what that pulling that viscera forward does basically puts a kink in the system, which makes it theoretically harder to go to the bathroom. It's not an actual sphincter from the point of view of it encircling either the urethral opening or the rectal opening, but it's a piece that adds to that basically blocks anything from dropping any farther down. Okay? And that's why it's called levator ani. It's because it anchors that and pulls it forward, putting a bend in it. Okay? So we'll stop. Well, no, let me add, because this just adds to that. So here again is that same image. Here is our tendinous arch. Here are our obturator muscles. Here's piriformis. If we look at this on a mid-sagittal view, so cut right down the middle, everything's removed that we don't want to talk about, including iliacus. So here's L5. Here's the promontory, our sacral promontory right here. If we wanted to do that, we could go along this This is the separation between the false pelvis and the true pelvis. And now we see, forget coccygeus for a minute, but now we see the relationship of piriformis and obturator internus to this posterior side. Here's our sacrotuberous ligament, sacrum to ischial tuberosity. That forms the attachment of our gluteus maximus muscles. Here we have obturator internus coming off that obturator membrane, sweeping around posteriorly underneath the spine of the ischium to then go out to the femur. Here's piriformis coming off the anterior part, anterior surface of the sacrum, going through the greater sciatic foramen to hit the femur. Okay? And here they are from the posterior side. Okay? So here's our ischial tuberosity, kind of down here. Here's the cut piece of sacrotuberous ligament. So that's what you're seeing there mid-sagittally. Here you're seeing it posteriorly cut. And now we see obturator internus. As it comes out, forms this tendon and comes over through that sciatic notch to then come into that trochanteric fossa. Here's piriformis coming off the anterior side of the sacrum, coming through the greater sciatic foramen. Remember, the greater sciatic foramen is just the notch from PSIS or PIIS down to the ischial spine, coming through that notch to the tip of the greater trochanter. Okay? When you look at them internally, here are those two muscles right there, lying inside the pelvis. And really, while piriformis comes off a little bit off of the tendinous arch, obturator internus goes underneath it, but forms a piece that that tendinous arch is attached to. Okay? So what we'll do from here going on Thursday is we'll talk more about kind of the relationship of these muscles and to the pelvic organs. We're not going to talk a lot about the specifics of the female and male reproductive system, other than what that some of the muscular pieces that are there specific to this. And we'll talk a little bit about the relationship of these muscles to the rectum and to the bladder itself, and not so much about differences in between male and female, gender differences in urethra and things like that. Okay? Mostly because since we don't really have a female cadaver down there to kind of reinforce that, it makes it a little more difficult. So, okay? So we'll focus on those. We will look in the lab, though, at male reproductive system. Okay? Any questions? Okay? So Thursday, hopefully we get through this early. We can have some review. We can go over some things. New stuff, old stuff, really old stuff. Then we'll go to the lab. We'll have that kind of the lab key kind of thing set up. And then whatever we can do between now. So tomorrow afternoon I plan to dissect more of the one cadaver, work on the other cadaver to some extent, flip the two that are down there that I want to reverse. And then just keep working on that, okay? So, are there any questions? Nice having a parking place, isn't it? I think so too. Okay. Yep.